Hi, Lucy. Thank you very much for making the time to talk today. I appreciate that you've had some pretty ultra urgent things happen with your diary over the last 24 hours or so, and we're all incredibly grateful that you've still managed to find some time to talk to us today.
Well, thanks very much, Nick. I would have very much liked to be with you in person, and if not that live, but some very unexpected last minute diary events have jumped in. And so this was so important to me that I really wanted to see how to be in conversation with you, and also just sort of be in communication with you and all those at the conference.
Marvellous. So we've had a really productive 2 days, actually. There's been about 80 of us here. This is our first face-to-face summit since 2019, since pre-pandemic. Big emphasis on networking and getting back together again, which has been fantastic. Amongst the delegates, it's not just been R&D leaders, but we've had really important partner organisations represented here too. The HRA, MHRA, we've had Department of Health and Social Care, NHS England, etc. So really productive discussions and some really constructive dialogue.
I mean, well, just on that, Nick, what that tells me is about sort of functioning as a system, not in silos. And I think that what you're describing as the attendees it's how it should be looking and feeling for all of us who are committed to improving the health and care research and research ecosystem. So it's really helpful to hear that there is that those other people present.
Yeah, and I mean, of course, it's really tough times to deliver clinical research within the NHS at the moment and in the wider healthcare system. But despite that, one of the things I've really been struck by in our conversations is, again, just the amount of energy in the room and lots of ideas about how we will develop our partnership working with those other organisations as well. So really uplifting couple of days and plenty of work to be getting on with once the summit closes later this afternoon. So one of the things we talked about when we opened the summit yesterday was how do we know that we as an R&D leadership community are having an influence? And of course, I fed back on the conversations that you and I have and the conversations that other members of UKRD have with your team. I guess it would be really helpful to kind of hear your perspective on where we are having influence and where we can build that influence through working closely with you going forward.
Well, I see UKRD as just an absolutely crucial part, and it really goes back to the heart of what I've said since I've been in post, which this is a team, very much a activity that is taking place as a team. There is absolutely no place for finger pointing and saying it is someone else over there. We all are part of and contribute to, I think, a health and care research ecosystem that has shown beyond many people's beliefs and understandings what we did in the COVID-19 pandemic, but even more importantly, what the foundational aspect of that is from pre-COVID, during COVID, and now post the peak of COVID. And I think there is a lot to show off, and I would really like to thank all of the people at the conference for the work they do every day, and what is often sort of behind the scenes, but completely crucial. So we are making a difference to the health and care outcomes of so many people across the UK and more widely. And I see people as such important parts of that system. And I've learned that from firsthand as a researcher and as a clinician of how we all play that part. So for me, that influence is about how do we continue to show that join up and that everyone is part of it and comes to this with that energy and enthusiasm that you describe, because together, working together, we can achieve so much more. So what I see that influence as being is sort of both on those within the system around research delivery, but also very much not forgetting that the work of so many people at the meeting is having an impact on patients and the public. And I've had conversations with my R&D team to say, how can we bring those together? I've often wondered, what would a program look like to get more people from the R&D offices into our research active clinics to say, this is what you can enable on a daily, weekly basis. So asking for R&D teams and investigators to do that join up at a local, regional, national level, and to go away with that. Why do we get up in the morning? We get up to make a difference. And with it comes some areas around how do we communicate, for example, meaningfully and intelligently about levels of risk and having a proportionate approach to risk. How do I communicate as an investigator and honestly with an R&D team about what do I think are the pinch points in the study, but where do I think it's fine? And I speak again from experience. If you pick up the phone to somebody, talk to them as a colleague, as a really trusted part of the team, you just get a completely different feel. So how do we replicate that nationally? Because that's how I feel about our R&D colleagues. I feel both one of them and also very, very conscious of the need to work together.
And it's interesting. It was one of the themes we've had here this morning. Actually, is in talking to HRA and MHRA around how we can work together to, I guess, kind of co-produce some of the improvements in the system that are really needed, so that it's not a case of finger pointing, but where improvements can be made within R&D processes, that we do them. But likewise, we don't want to create knock-on issues further downstream. And talking to Matt Westmore this morning on the panel, likewise, he doesn't want to make changes within HRA that then have knock-on negative implications elsewhere in the system. So a real sense that we can, I think, come together with some co-produced solutions.
And my plea is to your UKRD community, you know how to make things better. There is nobody with more expertise and experience in that part of the process. So how do we enable people to say, this is of low value, this does not add, this is not useful. We can do less of that because we want to do more of what has impact. And so I'm really interested in how we evolve in that way, because we're going to see evolution. It is on us. We don't need it imposed on us. We should own that. And the R&D community, as much as anyone else, should say, I think we could do things differently, smarter, better. And how do we get people to want to be part of that?
So that sounds like a really important challenge that we need to grasp, and it would be great to sort of develop that conversation with you about how we can continue to work together to identify those solutions and put some solutions into practice. So I've alluded to it already, but one of the things that one of the topics that has I guess run through a lot of our conversations is the concept of embedding research widely across all of our organisations, at a time when the NHS is under huge pressure. I guess we make this point probably in every meeting, but it just feels like we need to, because and personally I've been in R&D leadership for a long time, and I don't ever remember, in fact I'm sure there has never been a moment as tough as now to truly embed research in the NHS when so much else is going on. So it'd be really good to, I guess, continue to have a way in which we can, send signals out from the community about just what it's, the challenges we're facing, and where we might need to, work with you and colleagues to bust through some of those issues, or at least make you aware of some of those issues, so that we're all working with the same understanding about those pressures.
I think it's really helpful to hear that, and also to know that there's many parts of the system trying to get that same message across. For me as Chief Exec of NIHR, this is absolutely crucial, that we embed that research culture. And I would also say that research and innovation culture, because we can use different drivers when it's a research and innovation. And I see them as two sides of the same coin. Why does it matter? So I think it's really clear that research and innovation is good for patients. We know the data are on how those in clinical research do better, and it's also a field effect. So it's those units that are research active who have better outcomes. We know what the impact is for health and care professionals and the opportunities that we're seeing, particularly from within the NHR, to offer a whole variety of roles. And that includes, research managers in saying, how do you get involved? And to say, why does this matter for recruitment and for retention? And to really think about how we show value to research roles, including research management. It's also good for the system. I've mentioned that the research active communities, hospitals, trusts, wherever they might be, do better. And we need that across the system, and to embrace, for example, our new ways of working with ICSs. It's good for economic growth, particularly as we support the life sciences sector. So with all that overwhelming evidence, and with COVID, where the research really provided the answers and so much on diagnostics and treatments and vaccines, we've all got to keep up with showing how that is now relevant to here and now, at a time, as you say, when the backlog is 7 million and the NHS has got extraordinary pressures. And there isn't going to be a single magic wand solution to this. But I think if we can continue to work really constructively, both with our colleagues, but in a very much more these hybrid roles that you see across, whether it's management or clinical, are all going to be part of normalising research embedded. And asking, I'm not clear that anybody wants to stand still or to think that the health and care system is in exactly the right place. So research and innovation are part of the package that moves us forward. We've got NHS at 75. How important is it that research and innovation are seen as part of that forward-looking health and care system? And what we rely on for those at your meeting is to say they are part of that. They are part of normalising research in the system, removing the barriers, making it accessible, speaking all of us speaking in the same language, and being the champions for research that matters. So I think I've thought about this a lot over the last 18 months. We're not going to fix it overnight, but we can fix it one day at a time, one person at a time, to carry on just emphasising how rewarding it is and how important it is.
Yeah, it's really interesting comments there, actually, because a couple of things that we've talked about over the last day or so around almost dropping the R, dropping the research from what it is we do, because and therefore embedding the process of research as part and parcel of what an NHS organisation does for its patients. So that was a really interesting concept that came up. Another one was how we need to look at ourselves and say, are we communicating the outputs of research as well as we might? And I think, being completely self-reflective around the room, I think we feel that we should and could be doing more to really champion what difference research makes for our patients and for the system and how it operates. And to put those messages out much more effectively than they are at the moment.
Completely agree. It is not enough for the study to get done and to sit on a shelf. It's about the impact and the impacts it makes. And those impacts can be felt in many ways, both across the team, but for patients and public. But often it's what is the research doing for practice, for policy, but also for the workforce. Because if we don't look after our own workforce, then we'll have missed part of the point of all of this. So and I think we are also, in a positive way, seeing this. For example, CQC now has a well-led organisation, including research. It is that the GMC have embraced this with normalising research for doctors, and there are other research strategies for nurses, midwives, and allied health professionals. My vision is that R&D is a board level presence, a board level metric, and that it is just as important to delivering the care for the here and now to the how are we seeking to improve the health and care outcomes through the research and innovation. Because it shouldn't be an either or, and I know that sometimes it feels like it. We can't afford for it to be an either or. It's got to be core to care.
One of the other topics that we've talked about in at least a couple of our sessions is commercial contract clinical research, which of course is getting a lot of attention at the moment because of the issues with delivering commercial trials in the UK and pharma companies expressing their concerns and others expressing their concerns about that. So real energy here to embrace the challenge. But I also feel a real acknowledgement that this is a classic area where we do have to work with partners to make those improvements together. At UKLD, we've got a new working group set up working with pharmaceutical companies and ABPI to explore where those improvements can be made. And we've got some brilliant actions that have come out of discussions today with MHRA and HRA too. I suppose one of the areas of concern when we talk about commercial is the extent to which an unintended consequence of the focus on commercial, which everyone signed up to the need to make sure that we put the focus right and as a system we make the improvements. But the marginalisation potentially of the non-commercial research portfolio, which is so important in the UK, not just in its own right, but also because it makes a massive contribution to the thriving ecosystem on which commercial clinical trials can therefore thrive.
Yeah, I think this is really important. So I find it helpful to think in sort of some numbers. So we have around 6,000 studies on the portfolio. That is not the extent of clinical research in the UK because there is research not on the portfolio. We recruit about 70,000 participants a month to clinical research. By volume of studies, commercial is about 25% of the portfolio. By volume of participants recruited, it is about 2 to 3%. So at the moment, 98% of our participants recruited are to academic, charity-led. So I understand concerns around, is it a zero-sum game? If we expedite the commercial, will it disenfranchise other research? But I think that there is more than enough capacity for both, recognizing that we don't have infinite capacity. So part of me is saying, what are we doing about the incentives and the mechanisms by which we support both, recognizing that there's different reasons to do commercial, non-commercial. In fact, one of my sort of ideas is do we need such a binary commercial, non-commercial? What is the place for calling it all research for patient benefit, which is what it should be? Asking the three questions I ask: is it scientifically relevant? Is it deliverable? And does it have impact for patients and public? And if it's got those three pillars, then the commercial, non-commercial is secondary. So for me, it's about saying, how do we have an equitable offer that is got the right mechanisms, that allows both these several sort of academic, charity-driven and commercial partners to be part of the research ecosystem? And how do we get high quality scientific research? And I think hopefully through the routes that we are taking, we will see the same high scientific quality, the same deliverability, but rather than having a 98%, 2% split of our commercial, non-commercial, we start to think about what is an offer that is more appealing to the life sciences companies, so that we can support patients getting access, particularly to the early pipeline of drugs, devices, and diagnostics faster than if we had a lower commercial portfolio. So I'm not sort of unaware of the pressures, and I am very keen to work with our pharma and devices medtech to say, how can you help to be part of that? How can you look at your protocols with the regulators and say, how can we make them most efficient, most streamlined, and work with us to deliver that?
Thank you. We had a really good discussion this morning, actually, about how promising it was and how positive it is that we're engaging in really good discussions now with pharmaceutical companies. We had one of those sort of knitting type conversations where we were thinking about how do we make sure that we've got all the input we need in the room, because we're aware that there are lots of discussions and conversations going on at different levels, different organisations, and so there's something to be done, I think, around how we just make sure that each aspect of the system is talking to each other and sharing that knowledge through the dialogue we have with industry.
So, for example, I'm sure many of your members will have heard about the move towards more streamlined contracting. So again, who's got the knowledge and expertise? It's your members. How do we work with them? And that is what I see happening, to say, where do we add value? So the life science companies very much want to not do multiple parallel negotiation. And so what we're looking at is doing high quality negotiating with one lead site, using the model templates, using the costing tools, and then de-risking it for the other sites to say that lead site's done a good enough job, and how can we use the resource in R&D offices more efficiently. And for the very large majority of trials, then that will be the right model. And then we've got to look at where we need added checks and balances. But how do we take the R&D community with us on this so that they feel involved, valued, and that is a model that they want to use because it is a better use of their time. And learning from COVID, learning where we did do this and it went well, and then saying, what can, by getting those people in the room, how do we all move forward together? But I'll really want to be keeping closely talking to the R&D community about where this goes well and where we need to continue to evolve it.
And you'll probably therefore be really pleased to hear actually that we had a bit of a conversation about NCVR, and although uptake is probably a bit lower than anyone would like at the moment with NCVR, I think there's a really good dialogue building around what would it take to up that rate of adherence to NCVR, what needs to happen, with the tool itself and the system itself in order to increase engagement with it. So some good positive thoughts coming out in that respect from the summit. Another really amazing aspect, amazing statistic actually, is that I think about half of the delegates here today are from the field of mental health research, and we've hatched plans in a session earlier yesterday afternoon actually for a nascent mental health research working group. There's such a need and demand for that across the community that we're going to set it up, and I guess that comes from a couple of things actually. Just a concern or a fear that perhaps mental health research is feeling a little bit on the periphery, on the margin, particularly when we think about some of the things we've talked about here, and putting more emphasis on commercial clinical trials, which historically, of course, is not a big area for mental health. So I wonder if there's anything that we can do together to work on raising the profile of mental health research and really giving it the profile that it needs, given the huge burden that it has for our population.
So I'm really heartened to hear about that growth of that the interest from the R&D community, and I share it for a number of reasons. Partly because I think that we should look at how we integrate physical and mental health, and where there is value in understanding challenges, particularly for mental health research, but also where we continue to harmonise those areas and look for commonalities. So, and I look at the work where, for example, patients with multiple long-term conditions, where mental health may be one of those, and we need to ask for all of our research, have we considered the mental health inclusion perspective? So where do we make it part of everyday business, and where do we also ensure that we are creating research systems that are particularly accessible to those, say from the patient community, with relevant to particularly mental health on its own. From the commercial point of view, the launch of the Mental Health Mission, particularly through the NIHR Translational Research Collaborative, has been really welcome, because what we're seeing is a network across the country, and with work particularly, for example, the Mental Health Mission and the TRC is going into centres like Birmingham and Liverpool, and that will be followed by other sites with high disease burden, but less well served. And will be looking to the R&D community who have got expertise in this area to say, help us make this stick, help us make this happen, and in ways that we might not have traditionally considered. So not just a very secondary care focused. So how do the mental health R&D community champion a much more inclusive approach, both from how we conduct research, so across primary care, community care, and be the champions for research inclusion more widely. It's very clear that from a science perspective, that research inclusion piece is important, and mental health, that patients with mental health needs or mental health research as a topic is a really key part of that. So I think you will see ongoing messaging out of NIHR, both about why this continues to be important, how we want to see these initiatives developing, and how the R&D community can be real cheerleaders for this.
That's great, really great to hear. And it actually leads on to the next topic that I wanted to raise, which is around getting more research underway within community settings, and that phrase sort of non-NHS organisations. Obviously, something that we're looking at and seeing how UKRD can have a positive influence in that respect. And I guess quite a bit of discussion about, you know, if we're going to do more within those settings, what are the implications for the rest of our national portfolio? And of course, no one expects anyone to wave a magic wand and create a whole lot of additional funding or large amounts of additional funding. So it's whether we need to morph our existing research portfolios within traditional settings, acute settings, academic trust, etc., and do things differently to create the capacity, or whether there's new ways of partnership working that we just need to work together on and identify in order to make this happen.
I think you've named it really well. So I think the R&D community can be the catalyst to looking at the clinical pathways and saying it isn't all about secondary care visits. So looking at the opportunities across studies to say, are we offering research to the right patient group at the right time in the right place, and being very much supportive of initiatives that are not secondary care centric, because there's so much more, particularly after COVID, that can and should be, I mean, decentralized has got lots of meanings, but essentially following the patient, not our health system model. So one aspect of it is really saying, how do we take our existing structures and adapt them and evolve them to the changing clinical pathways, so to make research follow that for the patient. But there is another aspect which you touch on, which is how do we just design and deliver research in the right place. So for example, public health research, if you look at our work with local authorities across projects like the health determinants research collaborations, in social care, and as well as sort of community care more generally, I think we're going to need to grow the expertise that sits typically in R&D in trusts, and say, share that across ICSs, and spearhead that inclusive ICS wide. We know that the ICSs are less R&I mature than the trusts have been because of how it's worked out, but there are huge opportunities for R&D offices to think more broadly and to invite people from those settings in. I know that there are already strong links in many places around the country, but we can go further. So I think it's about always asking, what can we do with the existing portfolio, and then saying, how do we utilize those opportunities? And I think it's hugely helpful to think of how the R&D community go and open the door to those other colleagues and welcome them in. One of the things that we talked about through the NHS England ICS offer, research offer for ICSs, is focusing on the core 20+5, which is to address health inequalities. Because if you want to work in a more inclusive way, then thinking about it against those key health inequalities is a really strong messaging across an ICS. And we think that there's opportunities there to look in those 5 core 20+5 areas to start the ball rolling, to start the conversations with local authorities, community trusts, social care providers. So hopefully that's something that the R&D community can take away.
Yeah, absolutely. I'm sure we can. And It's been really great actually to see here that we've got several ICSs represented and been an active part of our discussions actually, which yeah, sets the scene for, I think, some really productive working going forward. So Lucy, I think that brings to an end our time actually. So I really appreciate you making the time to have this conversation and to hear a little bit about what we've been talking about at the summit, and to get your initial responses on all of that as well.
I mean, what I reflect on is that firstly, we could have talked about so many more things. It's a very, you know, I really value the ability to talk to you, Nick, and to talk to meet other R&D teams across the country. And I very much hope that I can be with you in person in future. But it's not about just these meetings, it's about all the actions and the conversations that continue in the intervening time. This isn't just a show for today, this is a regular, you know, conversation, as you know. And I would again come back to thanking the UKRD membership for what they do on a daily basis. It really makes a difference, and to invite those ideas that will help us evolve the system as a whole to do what we all feel so strongly about. So thank you very much, and I hope that, as I say, it's the first of many more conversations.
Thank you, Lucy.